In 70s and 80s, multiple methods were being utilized, and later on, initially it included some French method as well, in which certain plaster was applied. Then there was a kite method as well, in certain taping and plastering was done for the child along with the physiotherapy, and foot was actually gradually molded into normal shape. But an Italian scientist and Italian physician, Ignacio Ponseti, which was the one who actually introduced a conservative treatment of the congenital Talipes Equinovarus, called as Ponseti method of casting. And this Ponseti method of casting was actually a highly successful way of actually treating clubfoot disease, especially by simply casting in the neonates or the children who are just in infants or in neonates as well. This started with, the method was actually to start casting of a child as early as possible. In some cases, they started the casting in neonatal age group. In some, it was when the child was just 2 to 3 months of age. And as it was realized that the success rate was about more than 90% of the time. And so what was done was that children were brought to a certain center along with the parents. They remained there for 1 month, and this cast was repeated at 5 days interval. And then within 6 to 8 casts after this, the whole foot was actually corrected. And at the end of the last cast, which is that was the 6th or the 8th cast, tendon was done, and again a cast was completed with 3 weeks duration. It was slightly variations there. According to initial method, it was 5 days, but now 7 days is a general practice method, and that you cast child on, for example, on 1 day, and after 7 days you call them back, you remove the cast, you do all the physiotherapy, and then you reapply the cast. And then you keep on doing it by correcting it one thing at a time. That is, you correct the cavus first, then you correct the forefoot adductus, then you come at the hindfoot Equinus and Varus, and once you've corrected all, then you do the sternotomy at the last cast, and you apply the cast for 3 weeks. And after the 3 weeks, you give orthosis or certain splints which can be given as well. This is, you can appreciate, is there the cast has been removed, and now some form of physiotherapy is being carried out, so that the stretching exercises actually help to stretch the soft tissue over a long period of time. The casting is important because it starts with the mnemonic called as cave, that is the cavus first. You correct the forefoot cavus at the very first cast, that is, you push the head of the first metatarsal up, make it show that it goes up as much as possible, so that cavus or the medial crease which is present is actually corrected. Once that is corrected, and in the next cast you probably go for the forefoot adductus. Sometimes it takes 2 casts to actually correct the cavus if it's slightly rigid, but usually within a first cast you can correct the cavus, and then once that is done, you correct the forefoot adductus, that is, you bring the forefoot into the midline. And once that is done, within 1 to 2 or maximum 3 casts, and then you move towards the hindfoot, that is correcting the Equinus as well as the Varus as well. So what is important to see in the initial cast, you can appreciate that probably the foot is in the Equinus position as compared to the other cast. Now this is probably when they are moving towards the hindfoot and gradually correcting the Equinus, and the foot has come into a neutral position. If you see, this is the classical example. This is how it all starts. You can appreciate there is only the cavus has been corrected. There is mild forefoot adductus is present as well, and hindfoot is in full Equinus and Varus. They've corrected the adductus, and the hindfoot is still in Varus, and now at this 3rd or 4th cast, they've started to correct the hindfoot, Equinus and Varus, and eventually leading to this thing in which this is important, that you have to achieve abduction of about 70 degrees. That is, the foot should be in abducted position from the Varus about 60 to 70 degrees, and you have to achieve 15 to 20 degree of dorsiflexion, which is, this is the final cast position. Once that is done, this position is achieved, you can go for tendon sternotomy and apply this cast for at least 3 weeks. This is the final cast which can be applied for 3 weeks, And once that is done, after 3 weeks, you remove the cast, again provide the stretching exercises to the child, and then go for orthosis, which is called as DB splint or Dennis Brown splint. We can also go for foot abduction orthosis as well, but usually more commonly is utilizes DB splint or Dennis Brown splint. These are specific type of shoes which is actually available, in which the distance is between almost more than 1 inch between the two scapula of the child. They measure the distance between one scapula and another scapula, or one shoulder to another shoulder, and usually keep 1 inch more than that distance if the child is, and then they make it sure if it's bilateral, this is kept in almost 60 to 70 degree of abduction with 15 to 20 degree of dorsiflexion. And if it's unilateral, that foot is kept in 60 to 70 degree of abduction with 15 to 20 degree of dorsiflexion, but the other foot can be kept in neutral because it's a normal foot. From then we go off to this DB splint. And why this Ponseti method of serial manipulation casting was highly successful, because it gave with the mnemonic of the cave, because the problem was at the forefoot, midfoot and hindfoot, and the guide method and French method not exactly were elaborative enough that which problem should be corrected first. According to the Ponseti or Ignacio Ponseti, the cavus of the midfoot should be corrected first. Once you've corrected the cavus, then you can go for forefoot correction, that is the adductus of the forefoot can be corrected. And if you have corrected the midfoot and forefoot, then only go towards the hindfoot, because if you're correcting the hindfoot and with the talus medially rotated as well as in the plantigrade function and cavus is present, it will actually resist the movement of calcaneum upwards. Therefore, the varus and equinus will not be corrected properly, and eventually there will be problems and complete correction will not be achieved. So this was one way, because once you have corrected the cavus, you lifted the first metatarsal head up, the talus moves upward and it stops from being medially rotated. Therefore, the calcaneum gets enough space to actually come upward slightly. Therefore, equinus and varus is the calcaneum can be corrected, because now we have a space available for calcaneum to derotate, because it has rotated due to the malabnormality or malpositioning of the talus. Therefore, we correct the cavus first, then comes the forefoot adductus, varus and equinus. Ignacio Ponseti's treatment was a bit of a revolutionizing in the treatment of the clubfoot, and majority, almost more than 90% of the success has been achieved at different centers worldwide, and it's now a standard treatment of choice. If a child comes to you within the first year or even up to sometimes 3 years as well, some articles recommend that you start with the conservative treatment. That is, you give them stretching exercises, you give them Ponseti cast, that is to correct the cavus, adductus, varus and equinus, and at the end of the last cast you go for tendinoachilles stenotomy as well, and give DB splint. Usually more than 90% of the time it's absolutely successful, and all the deformity is being corrected, and the child is able to walk as run without any need of any surgery. But yes, in 8 to 10% of the time there is a relapse of problems. For children develop rocker bottom deformity or certain deformities along with this is called a dorsal bunion or forefoot supination. This is usually because of the problems with the musculature as well, and once that happens we may have to go for certain surgical procedures. But overall, Ponseti method of casting is a very good method to treat clubfoot.